Welcome back to the Deep Dive. Today we are digging into a supplement that has generated a mountain of evidence, and maybe an even bigger mountain of confusion, omega-3 fatty acids, specifically EPA and DHA. You walk into any store, you see shelves of this stuff, but figuring out if it actually works. And for what? It's a labyrinth.
It really is. I mean, omega-3s are everywhere. They're so widely used, but the evidence we've sliced through for this, a huge stack of high-quality human trials, meta-analyses, it is so incredibly specific. So if you're out there taking fish oil for, just general health, this deep dive is probably going to dramatically refine your expectations.
Absolutely. Our mission today is to cut through all that marketing hype and deliver some precision knowledge. We want to give you a clear, actionable guide based only on the most trustworthy human data out there.
When it works, how much to take, and what type of omega-3 is actually proven to be effective. And we found this definitive ground rule across all the sources. It's really the starting point for this whole conversation. The benefits are fundamentally condition-specific.
Right.
They're dose-dependent, and critically, they're form-dependent. If you miss the nuance on the dose or the chemical form, you could genuinely be missing the benefit completely. We're here to separate the high-certainty stuff from, well, all the low-certainty claims.
Okay, so let's unpack that. Let's start with the area where the evidence is, without question, the strongest, the cardiovascular core. This is where omega-3s really earn their stripes, but like you said, only under very specific circumstances. So first key takeaway, the most reliable finding, right? The robust ability of EPA and DHA to lower triglycerides.
That's it. That's the high-certainty benefit. For adults with elevated triglycerides or metabolic syndrome or diabetes, omega-3s reliably produce a clinically meaningful drop. This is the one consistent win, validated again and again.
But, and this is a big mart, you're not getting this by taking, a typical little 500 milligram capsule from the supermarket.
Yeah, not even close.
The sources are crystal clear on the volume needed. We are talking about pharmacological doses, typically 2 to 4 grams per day of combined EPA and DHA.
2 to 4 grams. And the mechanism is proven in humans. If you're hitting that 4-gram daily dose, you can see reductions of like 25 to 30%. It works by telling the liver to produce less VLDL-TG.
And VLDL is the main shuttle for fat, basically.
Exactly. So it reduces production, and it also helps your body clear the existing triglycerides from your blood faster. It's a really powerful direct metabolic effect.
So triglyceride lowering is a slam dunk. High dose, it works. But here's where the conversation gets critically nuanced. This is the biggest mental shifts for most people.
Right.
The benefit for reducing major cardiovascular events.
MACs, yeah. Heart attacks, strokes.
Right. That benefit is highly conditional. It doesn't generalize.
That's the crucial distinction. When people talk about fish oil protecting the heart, they're often mistakenly referencing one very specific trial that used a pharmaceutical-grade pure compound.
You're talking about the massive Reducide trial.
That's the one.
It gave us incredibly strong evidence that 4 grams a day of pure EPA monotherapy, this stuff called icosapent ethyl, it reduced MEs by a significant 25%.
And the conditions for that benefit are just non-negotiable. That massive reduction was only in a very specific high-risk population.
Okay, what population?
Patients who were already on statins, but still had stubbornly elevated triglycerides. So secondary prevention, high-risk patients.
So high-dose pure EPA and a specific high-risk patient group. Now let's contrast that with the other big trials. This is the real aha moment.
Exactly. Look at the VITAL trial. It tested a much lower dose, only 1 gram a day of mixed EPA and DHA in a general population.
Yeah.
No consistent MACE reduction. Then there's the STRENGTH trial. It used the same high dose as Reduce It, 4 grams a day, but it used a mixed EPA and DHA formula.
So not pure EPA.
Not pure EPA. And that trial also came up null, no benefit for MACE reduction.
So this is where we have to pause. Why would 4 grams of pure EPA work so well, but 4 grams of mixed EPA and DHA fail?
There are a few hypotheses, but the takeaway for you, the listener, is this. That cardiovascular event reduction benefit is proven only for high-dose EPA monotherapy in that specific group. It does not generalize to your typical over-the-counter mixed fish oil for general prevention.
That distinction is just, it's massive.
Yeah.
And it really hammers home this idea that omega-3 is a precision instrument, not a blunt tool.
Absolutely.
Let's shift to the brain. This is where so many people start supplementing. For mental well-being, specifically major depressive disorder, there is a signal, but the certainty is lower, low to moderate.
The signal's there, but it is tied to an even stricter rule. We call it the EPA ratio rule.
The EPA ratio rule, explain that.
The benefit we see for MDD seems to be overwhelmingly driven by EPA-dominant formulations. Meaning for the supplement to work, the label has to show that EPA makes up at least 60% of the total omega-3 content.
So if I buy a product that's heavy on DHA, which is always marketed for brain health, I might be wasting my time if my goal is depression.
Precisely. DHA-dominant or DHA-pure formulas have consistently failed to show a benefit in depression trials. This is why you have to read the fine print on the label past the big total omega-3s number.
You need to see the specific EPA and DHA breakdown.
Yes, and you're looking for a total ETA intake of around 0.5 gram to 1 gram per day.
And we should stress, this is typically seen as adjunctive therapy, a supportive role, not a replacement for primary treatment.
Correct. The effect sizes are modest, but the anti-inflammatory theory, it holds up. Human studies suggest EPA helps modulate inflammation. We see reductions in markers like IL-6 and CRP. So the mechanism seems plausible.
What about anxiety? Is it the same EPA dominance rule?
Not necessarily. The evidence for anxiety is also low to moderate. Some meta-analyses do show a reduction in symptoms, especially in people under high stress. But interestingly, some studies suggest the effects might be stronger at higher combined doses, maybe around 2 grams a day of combined EPA and DHA. The optimal ratio might be different or just less strict for anxiety than for MDD. It's a bit messier.
Okay, so let's address the big one. The big letdown, really, for the largest part of the market. Cognition and dementia prevention. Is the science as strong as the advertising?
Unfortunately, no, not for prevention. If your main goal is taking a pill to prevent cognitive decline or dementia later in life, the evidence is just weak. Low certainty.
And we're talking about major respected trials here, right?
Oh, yeah. Huge, high-quality RCTs, including the landmark ARES-2 trial. They have consistently shown no consistent benefit of routine supplementation for this. For a healthy, older adult, taking a supplement just doesn't seem to reliably shift their long-term risk.
So the current robust human evidence does not support using omega-3s solely for general dementia prevention. That is a really key piece of clarity.
But while the generalized claims are weak, there are these niche conditions where the benefits are proven with moderate to high certainty.
Like rheumatoid arthritis. That's a strong one.
It is. We have moderate certainty evidence that supplementation improves patient-reported joint pain and stiffness. That's a huge quality of life win, and it might even reduce the need for NSAIDs.
But again, the dose is key.
Always. The effective doses were high, 2.7 grams per day or more of combined EPA and DHA. And you have to stick with it for at least 3 months to see that reliable effect.
And there's another crucial high-certainty benefit in pregnancy.
This is a big win, supported by the highest level of evidence. For pregnant women, DHA supplementation is highly effective at reducing the risk of early preterm birth, that's birth before 34 weeks.
On the dose.
It's specific and achievable, 500 to 1,000 milligrams of DHA daily. It's a really powerful, protective intervention.
Now let's zoom out to the ultimate claim. Longevity. All-cause mortality. If I take fish oil every day, am I going to live longer?
The evidence for an intervention effect it's low to very low. It's true that observational studies, the ones that measure the omega-3 index in your blood, they do link higher levels to lower mortality.
Wow.
But the large, long-term RCTs of supplementation generally show no consistent reduction in all-cause mortality for the general population.
So we have that classic correlation versus causation problem.
Yeah.
People who eat a lot of healthy fish tend to have better health outcomes. That's correlation.
Right.
But the idea that I can just mimic that by taking a daily capsule, that's causation. And that's not reliably proven.
Exactly. And this brings us to probably the most critical safety signal that everyone on high-dose omega-3s needs to know about, atrial fibrillation, or AFib.
Wait, so if I'm taking high doses to protect my heart, I might actually be increasing my risk of an irregular heartbeat. That's a huge trade-off.
It absolutely is. This is a moderate certainty finding. Meta-analyses of those big cardio trials show a small but consistent increased risk of AFib, particularly at those pharmacological doses above 1 gram per day.
And the numbers are concerning.
They are. We saw pooled data showing something like a 20 to 25% higher AFib risk. For example, the Reduce IT trial, the one with the great results, it reported a higher rate of AFib hospitalization in the group getting the pure EPA.
This is non-negotiable advice then. You have to be cautious if you have a pre-existing risk of arrhythmia or if you're using high doses. You have to discuss this with your doctor.
Definitely. On a less severe note, what about the old fear of increased bleeding risk?
The sources are pretty reassuring here. The big trials show no increase in fatal bleeding. You see, maybe small increases in minor bleeding.
Like nosebleeds or bruising.
Exactly. And even that is mainly at the very high doses, around 4 grams per day. The fear that standard doses will cause major bleeding just isn't supported by the data.
Okay.
And for interactions with blood thinners like warfarin, while standard doses don't consistently cause issues, clinicians still advise close monitoring if you start a high-dose regimen.
Makes sense.
So we've established efficacy is all about the target, the dose, and the form. Before we get into the secret of absorption, let's just clearly summarize the 3 clinical doses we've identified.
Good idea. Here are the 3 numbers from the successful trials.
Right.
1. For robust triglyceride lowering, you need 2 to 4 grams a day of combined EPA and DHA. 2. For that high-risk CV protection group, it's 4 grams a day of pure EPA.
Pure EPA.
And 3. For depression, as adjunctive therapy, it's around 1 gram a day of EPA from an EPA-dominant formula.
Perfect. Now, this final segment might be the most actionable part of this whole deep dive because it dictates whether those grams you just swallowed actually get into your system.
Ah, yes.
Absorption.
Why does the chemical formulation matter so much? The difference between, say, ethyl ester and the other forms.
It's all about bioavailability, how well your gut can actually use the oil. There's a hierarchy. The reesterified triglyceride forms, -RTG and phospholipid forms, like in krill oil, they generally show better bioavailability, especially if you take them without food.
So if I buy a cheaper concentrated supplement, it's probably that ethyl ester or EAE form. Am I just wasting my money if I take that with, say, black coffee in the morning? You might be absorbing very, very little of it. And this is the golden rule. The problem with ethyl ester forms is that they're engineered. They're not structured like natural fats. Human studies confirm EE forms have 3 to 5-fold improved absorption when taken with a fat-containing meal.
3 to 5 times better. That is a massive, actionable difference.
It is. Think of the ethyl ester form like a raft. It needs fat in your meal to act as the boat to carry it across the intestinal wall. If you take an EE supplement on an empty stomach, it's often poorly digested. That's why people get those fishy burps.
Oh, the oil is just sitting there.
It's just sitting there undigested. You might only be absorbing, 20% of the active ingredient.
So if you're trying to hit that 4-gram clinical dose, you need to be taking it with your biggest meal of the day, or maybe splitting the dose 2 grams at lunch, 2 at dinner to maximize absorption.
Precisely. Splitting the dose and making sure it goes down with dietary fat. That's the difference between a potentially effective intervention and just expensive oil passing through your system.
This has been an incredibly specific deep dive. We've really established that omega-3s are not a magic bullet. They're a highly specialized tool with a very specific user manual.
The key is specificity. For cardiovascular benefit, the evidence is narrow. High dose, pure EPA for high-risk patients, and 2 to 5 grams combined for triglycerides. For the general population, the evidence for reducing heart attacks is weak.
And for mental health, it's all about EPA dominance. Around 1 gram of EPA daily as adjunctive support for depression. And just forget it for general dementia prevention. The trials don't support it.
And please remember the practical steps. Always check the label for the EPA content and the chemical form. If it's ethyl ester, you absolutely must take it with a fat-containing meal.
So that leads us to a final provocative thought for you, the listener. It connects everything we've talked about. Evidence consistently shows that a higher measured biomarker level in your body, the omega-3 index, correlates strongly with better outcomes, even when the supplementation trials sometimes fail.
So the ultimate question isn't just, am I taking enough capsules, but rather, am I absorbing enough to actually raise my body's baseline omega-3 index into that protective, clinically relevant range? That is the crucial distinction we're thinking about.
A great point to end on. Thank you for joining us on this deep dive into omega-3 fatty acids. We'll see you next time.